Everybody, this is the lecture we're going to talk about for drug exam number 12. And first of all, let me welcome you to cardiology. Cardiology is like my favorite thing to talk about. So I enjoy this topic. And the nice thing about this is now we're getting into medications that we are going to give frequently. The last few lectures have been more about medications that we need to know about, but are not something we give on a regular basis. But that is not the case going forward because a lot of these medications we give a lot. So the first one we're going to talk about today is Adenocard. Another name is adenosine. And adenosine is a very, very interesting medication. We would give it for a stable supraventricular tachycardia. Supraventricular tachycardia is kind of a bucket because when the heart is beating really fast, it's hard to interpret where the rhythm is coming from electrically. So we can't really say it's atrial or junctional or a fib or any of those things because we just don't know because it's so fast. And one of the characteristics of SVT is you can't see the P wave. So we have trouble with that. So instead of saying it is for sinus tach, we say that it is for any narrow complex tachycardia and that originates, because it's narrow, it originates above the ventricle. So supraventricular tachycardia, above the ventricle tachycardia. And how adenosine works, it is a very short-acting medication that slows conduction. And really, when you think of adenosine or Adenocard, I want you to think of your turning it off and turning it back on again, or Control-Alt-Delete on your computer. And what this basically does is this stops conduction of electrical activity through the heart. Now, you might hear that and say, what? It stops conduction? That is true. It does stop conduction. But the medication half-life of this adenosine is only 10 seconds. So when you inject that into somebody, in 10 seconds, that medication is going away. It is going to be a very short-acting medication. The body metabolizes it really, really fast. So it's good in the fact that it will do that kind of hard restart of the heart. The problem is if we don't give it in a way that gets it to the heart as quickly as possible, it's not going to work because the body has already metabolized it if we don't give it quickly. So typically with adenosine, if we see that we need to give it for SVT or a stable VTach with a pulse, we will start with a dose of 6 milligrams rapid, and I mean rapid, IV push. Now, not only do we need to push it fast, we need to have an IV conducive to allow us to get that medication to where it needs to be within 10 seconds. So we need to start a larger IV, preferably an 18, and it needs to go in the left AC. The left AC is the closest IV access that we have to our heart. So left AC is where we want to be for the administration of adenosine. So if we give 6 milligrams of adenosine, it might not work. So we can give a subsequent dose of 12 milligrams rapid IV push after just a minute or two, because by the time we draw it back up, we can go ahead and give that second 12 or that first 12 if it doesn't, if that first 6 does not work, 6 milligrams and 12 milligrams specifically. Now, ACLS no longer calls for another dose of adenosine. They kind of figure if 6 didn't work, 6 milligrams and 12 milligrams didn't work, then probably the next 12 milligrams isn't going to work. but your local protocols might say 6, 12, and 12. That's something you're going to have to figure out once you get to your trucks where you're going to be working and see what that protocol is. But it can be 6 and 12 or 6, 12, and 12 depending on protocols. Now, how the adenosine works is it blocks conduction through the AV node. So we don't allow that electrical impulse to get through the AV node down to the ventricles. So it stops that conduction just momentarily for like I said, like 10 seconds. So the patient might feel like a rush come over them. They might have this sense of impending doom. All those things are very normal. Now, sometimes when we have SVT, and those QRSs are so close together, it's really difficult to tell if the rhythm is regular or irregular. And now, why is that important? We know that if the rhythm is irregular, there's a good chance that it's going to be atrial fibrillation with rapid ventricular response, AFib with RVR. And adenosine won't really convert that rhythm like it would a SVT, a sinus rhythm, okay? Because it potentially is not originating in the sinus, the SA node. So, but what it can do is it can sometimes slow that rhythm down, slow that conduction down to where we can take a look at it and say, oh, that's not a sinus rhythm, that is AFib. And we have another medication that we're going to talk about in just a couple minutes that is much more effective on AFib with RVR. So remember, left AC, rapid push, followed by a rapid push of a flush. The next medication we're going to talk about is amiodarone. Amiodarone is an antidysrhythmic, and it's kind of like three drugs. It's like a three-drug cocktail. And what that three-drug cocktail does is it blocks sodium channels, it blocks potassium channels, and it blocks calcium channels in the heart. So it can really prolong our action potential and really calm the heart down if it's having problems, or if we have a patient that's in VFib or pulseless VTAC. The traditional dose for it is 300 milligrams, followed by a subsequent dose of 150 milligrams after 10 minutes. It is a good medication. Some protocols will tell you to use lidocaine. Lidocaine can be used interchangeably with amiodarone, and some protocols will say to use amiodarone first. Follow your local protocols, do what your medical director tells you to do, but some agencies will give you the provider discretion whether they want to use lidocaine or amiodarone. Now, I'm an old man and I have been around longer than amiodarone has in the pre-hospital setting. So I typically lean towards lidocaine, but that's something you're going to have to learn and decide for yourself as a provider. Remember, you get to choose the provider you want to be. The next medication we're going to talk about is atropine sulfate. Atropine is a medication that will increase the rate of the heart rate. And now, that can be from several different problems. We can give atropine for organophosphate poisonings, but we've talked about in a previous lecture, and we're not going to talk about it here. We're going to talk about it just speeding up a slow heart rate. This is for a patient that has a stable or potentially unstable bradycardia, and it just turns up the heart rate. And the dose for it is typically 0.5 to 1 milligram IV push. Now, I will tell you that it used to be 0.5 was the initial dose, but ACLS changed that a few years ago. Your protocols might reflect the old dosage, but now they just say 1 milligram IV push, and that's to increase the heart rate. Now, if the patient's really unstable, we might have to go straight to transcutaneous pacing to increase the heart rate physically by externally pacing them. But atropine is a much less painful treatment than pacing. So if you have time, if you have a moment, you might, if it's unstable, you will want to try atropine first. But please keep in mind that we might need to pace this patient. All right, the next medication we're going to talk about is diltiazem or Cardiazem. Diltiazem or Cardiazem is a calcium channel blocker, and it slows conduction and slows action potential. Now the dose for it is 15 to 20 milligrams IV over 2 minutes, and then if that didn't work, to slow the rate down, after 15 minutes you can try a second dose of 20 to 25 milligrams IV over 2 minutes as well. And what it does is it inhibits extracellular calcium ion re-influx across the membrane of the myocardial cell. So basically it slows action potential. And a lot of times when we have an SVT and we give them adenosine first, we will see the rhythm slow down to where we can interpret the rhythm and find out that it's irregular. If we find out that SVT is irregular, or adenosine is probably not going to work. So then we need to think about a calcium channel blocker like diltiazem, and some agencies will not carry diltiazem. The one drawback to diltiazem is it has to be refrigerated. So some agencies won't carry it. They'll carry verapamil instead. But diltiazem is a much more effective medication for a calcium channel blocker than verapamil is. The next medication we're going to talk about is another antidysrhythmic, and it is lidocaine. Lidocaine decreases automaticity by slowing depolarization, slowing that action potential, and it calms the heart down. Typically, the dose is 1 to 1.5 milligrams per kilogram IV/IO, and we can give a repeat dose of 0.5 to 0.75 milligrams per kilogram with a total max dose of 3 milligrams per kilogram for the patient. We won't give more than that. Typically, it comes in a carpet jet with or syringe with 100 milligrams in the syringe, and it can be given for VFib or pulseless VTAC, and it can also be given via a drip. If we use lidocaine as an antidysrhythmic and we're successful and we get ROSC, we will want to start a lidocaine drip that is 1 to 4 milligrams in the drip. But now I want you to just focus on that 1 to 1.5 milligrams per kilogram right now in this lecture. Well, that's all the medications we have for this lecture. The next lecture will also be about more antidysrhythmics. As always, if you have any questions, please reach out to your instructor, and I hope you have a wonderful day.